Welcome everyone to a special episode of Let's Talk Patient Blood Management. You may be aware that February 13th is World Anemia Awareness Day. And with that in mind, we hope to bring you greater awareness of anemia and the nearly 2.5 billion lives it touches.
We want to take just a moment to really thank our sponsor, PharmaNutra, the makers of Cedarol. With their support, we are able to bring more education and awareness to both anemia and patient blood management. And also, we're excited to offer some solutions.
Yeah, definitely. I think it's very important to mention that since we started this podcast, we agreed to partner only with people who share the same mission, goals, and values as we do for patient blood management. PharmaNutra met our criteria, and as you will see by this first episode, such a valuable resource.
Marianne, I want to introduce you to Melisa Clark. Melisa is a nurse. She's been a nurse for 20 years, very well educated in medical practices, and yet she herself has struggled for many years with iron deficiency anemia. Her story is such an interesting one. She's willing to share it with you and the rest of the world, our audience. I'm happy to invite her onto the show. Melisa, welcome.
Thank you for having me.
Oh, yeah. Melisa, welcome. Thank you so much for coming on the show. We really appreciate it. We appreciate you sharing your story and your whole trials and tribulations through this process with us. Let's just get right into it here. Melisa, when did you recognize you would struggle with iron deficiency?
So, in order to answer the question, we have to back up just a little bit. I'm going to give you a little bit of history on myself. I became a nurse 2004. 2006, I had my first child. By 2008, I was working night shift as an RN. I was 353 pounds. I was depressed. I was exhausted all the time. So I went to a seminar given by a bariatric surgeon, and at the seminar, they do touch on iron deficiency anemia as one of the complications or post-op issues that you might come into contact with. I guess that's kind of when I first knew that it was going to be an issue. So you have to decide whether the benefit outweighs the risks.
And you felt like it did?
Absolutely.
And you moved forward with bariatric surgery. And what type of bariatric surgery did you have?
On August 27th, 2008, I had the Roux-en-Y gastric bypass surgery.
And so for our audience who are watching on YouTube, we'll share a visual of what that surgery looks like and what Melisa's digestive system now looks like. What is your digestive system like now?
Oh, well, I'm 16 years post-op, so my digestive system, although it has been surgically altered, I can pretty much eat what I want, drink what I want. I still try to follow the rules, but the game has changed a little bit. So I had to be much more cautious. However, I can eat red meat. I can eat things that provide iron orally, but they just don't absorb. An issue that people don't know about me is in 2019, I was diagnosed with renal cell carcinoma, and I lost my left kidney. So the combination of losing a kidney along with already being anemic was kind of a perfect storm. So that's when I was referred to blood management.
So often with the Roux-en-Y gastric bypass, the area that is cut away is the area that is most likely to absorb the iron nutrients. And so that is why gastric bypass patients often will struggle with the absorption of iron. So you then, how did you try to address your iron deficiency?
We did try orals, particularly after I had my first child. I was postpartum and noticing that I was starting to feel tired, but more tired than just a normal new mom would feel. So I started the oral iron, and when you're a gastric bypass patient and your digestive system is surgically altered, constipation becomes a real issue. So the oral iron was causing a lot of issues with my bowels. And when I would get my labs rechecked, it just wasn't doing what we needed it to do.
That sounds like a lot.
Yeah. Your health practitioner then moved on to IV iron. How was that experience?
The IV iron worked fantastic. The hematologist gave me the option of 8 small bags, so 8 visits to an IV infusion center, or 3 larger bags, or 3 visits to an IV infusion center. I opted for the 3, went through the course of treatment, felt fantastic. Labs were great. There was just one downfall.
Mm.
I certainly couldn't afford to do it again.
So were you insured?
Absolutely.
Okay.
I did have health insurance, but I think I don't know the basics of health insurance or why they choose to cover things versus other things. I don't know if it was what I chose, but the iron just wasn't covered like I was anticipating it would be.
Oh, okay.
Was that an enormous cost, or if you don't mind me asking?
Before it was sent to insurance, they were $10,000 a bag. And I was diagnosed with needing at least 3.
Oh my. Wow. That is incredible.
That seems quite cost prohibitive to take
Absolutely.
care of what
And
you
as a
had to take care
healthcare
of.
professional, it's frustrating.
Right.
You know what you need.
Oh my.
You work in the field, you see it, you know it, but it's a challenge to cover when you have a family, especially, life in general.
Yikes.
So it sounds like IV iron was very successful.
Absolutely.
Your symptoms, did you have more energy?
Much more energy, much more color. Like you could even tell visually, I looked better. I felt better, more energy. Yes. Sometimes I would get short of breath. That was one of the hardest things that I had to deal with. I would get gassed taking a shower. I would have to sit down in the shower. That's how bad I felt. And immediately after the course of treatment with the IV iron, that had improved. So I knew it was working.
Right. Absolutely.
So with this surgery, this will be an ongoing problem for you, right? So
Yes.
This is not just like you took it, you paid, you treated, you're done. This is going to be a lifetime process.
Absolutely. Lifetime maintenance.
So you've recently had your labs drawn again.
Correct.
And you've found what with your labs?
My ferritin is exceptionally low. So I have been referred to blood management by my primary care doctor.
So we're going to review your labs. And again, for those who are watching the YouTube channel, you'll be able to see Melissa's lab results. She's been so generous to share those with us. Marianne, being the nurse practitioner, why don't you kind of walk us through her labs?
Oh, sure. And thank you again for sharing your lab work with us. And yeah, this is just typical iron deficiency here. First of all, you got a CBC. CBC, that's a pretty normal exam that it's a good starting point for patients. And obviously you got a history and physical at the office. So we kind of look at the whole picture, your history, your physical symptoms, and your laboratory work is one big picture. Your hemoglobin and hematocrit, we'll start there, or part of your CBC, we'll start there. So hemoglobin, that's a protein in red blood cells that carries oxygen from the lungs through the body. And that should be 12 to 16, and yours was 10.5. So that was low. And your hematocrit is how much of your blood is made of red blood cells. And that number should be somewhere between 35 and 47, and that was 32.3. RDW, we kind of look at that with everything else. And that helps us see differences in sizes of red blood cells. So we look at this, again, overall picture to determine different types of anemia, kind of helps diagnose with heart disease, liver disease. And that was 18.2, and that should be 11.5. Another abnormal that you had was your mean corpuscular volume, or MCV. And that's the average size of the blood cells. If they are smaller than normal, you may have iron deficiency anemia or thalassemia. But if they're larger, that's when we start to think about B12 deficiency or liver disease, and that should be 80 to 100, and yours was 74. We already saw your hemoglobin and hematocrit were low, your RDW is high, and your MCV is low. So we're really looking down the path of iron deficiency anemia here, definitely with that MCV low. Again, in addition to your history and physical.
One thing I noticed too is that your hemoglobin was 10.5. And sometimes patients will go to their practitioners and they'll say, oh, you have this chronic condition or maybe bariatric surgery. So 10.5 is normal for you. But a 10.5 is not normal. And just because you are at risk for always running a little low does not mean that you have to. You need to find a solution for that. You have to remember that you're 2 units low. So when you think about a bag of blood that we hang and we give patients, you're 2 units under what someone who's normal like me is running at. So I'm not sure if you've been able or started to feel symptoms yet of your anemia, but soon you will be. You'll go back into that very exhausted state. And we know that because of your ferritin level. And I don't think you've talked about that yet, Marianne, right?
No, I haven't. And that's a really good point that, I think that sometimes we see people's laboratory values and it just kind of, it's low, 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 or it's high, high, high. And we start to say things like, oh, that's how they run and that's their baseline. But really, we should be a little more assertive in investigating these lab values, especially in the setting of symptoms. So, yeah, with that CBC, the next reasonable step to take is to take a look at the iron levels in the patient. They did that with you here. And with the iron levels, we can diagnose better different types of anemia. We can check to see if your iron is too high or too low. And usually we'll do an iron screen, or sometimes people will order a component of an iron screen, like just an iron or just a ferritin. Usually I like to see a couple of labs. I'll do an iron screen. So that consists of ferritin, iron, transferrin sat, and total iron binding capacity. It gives a good picture. So your ferritin, that shows how much iron you have in storage. And in this scenario, ferritin's complex. And in this scenario, we're zoned in on iron deficiency anemia based upon your history, physical, and your other labs. So we're going with ferritin in the setting of iron deficiency anemia. It should be 11 at a minimum, up to around 3.307, and yours is 3. So you have very, very little in the bag there. Your iron level is kind of variable. That's the amount of iron in your body at the time that you got your labs done. And that should be 50 to 70, and yours was 24. So also low. Next, we have transferrin sat. We see a low transferrin sat in chronic anemia, chronic infection, and inflammation. The normal number should be somewhere between 15 and 50, and generally less than 20 is indicative of iron deficiency anemia. And yours is 5, so very low. Yeah. And sorry, we're all nurses and we all laugh at these bad lab numbers, but they're not funny at all. Lastly, we'll talk about your total iron binding capacity, and that's how well iron attaches to transferrins and other proteins in the blood. And that's 250 to 425 is a normal number. And yours is 480. So that says to me that your body's working well to try to get out there and, attach to iron and get that iron out of your, and get it moving. And yours is really high. So your body's working well. There's just not enough iron there to make a difference. So, clinical picture based upon your history, your surgery, your physical exam, your symptoms, definitely iron deficiency anemia.
We did also see a B12 level, which it did fall, I know, into the normal ranges, a little bit of a low normal. We do know that is definitely the iron depletion that is causing your blood production to now be depleted. But it wouldn't hurt to increase the level of B12, certainly. As you've stated, you cannot afford IV iron again, correct?
Correct.
We want to introduce you to that product by PharmaNutra. We feel like this could be an answer for you, and we're really excited to bring it to you. Cedarol is a iron supplement, a nutritional supplement, but it's different than the ones that you find at Walgreens or on the shelf. It's formulated very different. And because of this, it has been clinically researched, and it has worked in patients like you with an iron malabsorption issue. The makers of Cedarol have been so generous to say, we would like to gift Melisa our product to see if it works for her. They are well known in the European markets, and now they are breaking into the United States, which I am so happy, because people who struggle, just like you, are on all these social media platforms, either saying, my physician is not taking me seriously, doesn't think that it's a big problem, I can't afford the IV iron, I don't know what to do, I'm exhausted, oral iron's not working for me. And so now we have this new product, Cedarol, that I would like for you to try if you're willing to try it.
I would love to try it.
What we'll do, Melisa, because we know that you're unfamiliar with the product, is we're also going to gift you 3 months of our coaching services.
It's incredible.
Mary Ann and I are patient blood management experts, and we can kind of help you along the way. So if you go to our website, you will see that you can book time with us. I'll be checking in about a week to see how you're doing on the Cedarol product. If you're experiencing anything, it's not supposed to have the GI constipation and things that you've experienced in the past. In about 3 months, if you would, we'll ask for you and your primary care physician to rerun your labs and see your success story, see how Cedarol has worked. We want to tell you about the costs. The cost of Cedarol is $89 a month. Is that something that would be feasible for you if you need Cedarol in the future? Because most likely you will.
That would be wonderful, Sarah. That's less than a cup of coffee a day.
Yeah. Really, when you break it down, if you buy a soda a day or a coffee a day from McDonald's, you could afford the Cedarol product. And for it to be successful, and the success that it's had in Europe, I think you're going to be very happy with the product.
I'm excited to give it a try.
Yeah, I'm excited for you. I think that, and it'll be interesting to see the differences in your lab values when you come back in a few months. I'm really positive about it. I think this will be a good opportunity for you.
And I'm sure that our audience is going to want to know also, if this worked well for you, do you mind coming back and sharing your results?
No, absolutely, Sarah.
We would love to have you back. This is not something that we want to keep you on our health coaching for a long time. Once you become comfortable with Cedarol, we really want you to share with your practitioner what you're doing and introduce them to Cedarol.
Mm-hmm.
Many physicians who are being introduced to Cedarol are really enjoying the results they're having with their patients. So please share this with your primary care physician. And once you get comfortable, you'll no longer need our coaching. You'll be receiving Cedarol. We'll get your address. It'll come to you in the mail. And also, we're going to gift you with this book, Bloodworks, an Owner's Guide. It has a lot of education.
Oh, fantastic.
Oh, I didn't know we were gifting her that. I'm so excited for you.
I'm excited as well. Yes.
News to me that you're going to love this book. It's a beautiful, it's a joy to read. The pictures are beautiful, and it's little short pieces that you can read and put down and come back to. And it's a wonderful book. Very informative. So we know that Cytoral is well established in Europe, and we happen to know a physician in Spain who's a patient blood management expert, Professor and Dr. Manuel Munoz. And Melissa, he knows your story, and we're going to talk to him and ask him to provide some additional insights surrounding your story. And you are more than welcome to hang out, but let me give him a little introduction here. Dr. Munoz is the professor of Department of Surgical Specialties, Biochemistry, and Immunology in the School of Medicine in the University of Malaga, Spain. And since 2000, he's been actively researching patient blood management strategies with emphasis on perioperative anemia management, bleeding control, and cell salvage. He has over 200 publications in the field, including original research, reviews, consensus statements, and book chapters. And many of the papers are focused on cedarol, sucrosomial iron. So, Dr. Munoz, thank you so much for joining us today. Would you like to say hello to our audience?
Thank you for this nice introduction, Marianne. I'm very, very pleased to be invited to participate in this podcast, because I'm pretty sure that it will help to all those having or suffering from iron deficiency or iron deficiency anemia. And it's my pleasure to be here.
The pleasure is definitely all ours, Dr. Munoz. You have heard Melissa's story, and we've provided you with her lab work. Tell us what you are expecting from her 3-month trial of Citarol, and can you give us any insights on her story?
Her lab just clearly defined a classical iron deficiency anemia, no doubt. The cause is the bariatric surgery she had around 16 years ago. And you know that bariatric surgery have it's a good way to lose weight, but have some inconvenience. And one of these is that you reduce the size of the stomach so much, you have to have a little pouch, and you provoke a diversion in the small bowel. That way, you don't have the acid on the stomach, and you don't have the surface of the duodenum. And these two things are absolutely needed to absorb iron. So that's why traditional oral iron will not work with this patient, and will not work with any other bariatric patient. What is the solution for that? Until recently, what we used to do is just to give IV iron. Depending on the formulation you have, you can give it IV iron every 3 months or every 6 months or once a year. That depends on the amount you can give. IV iron is not a simple medication. You have to go to an authorized clinic to receive it. It's very expensive. It's not risk-free because most of the side effects are mild, but sometimes you have severe. We were for a long time looking for a solution that filled the gap between oral iron and IV iron. And I think that sucrosomial iron could fill the gap. And why? It's because first, for the formulation, it's a nanoparticle. They have a core of ferric pyrophosphate, which is covered by a phospholipid layer and surrounded by the sucrosomial. That means that confer to this nanoparticle gastroresistance. That means that when you intake it and go through the stomach, it will not be destroyed by the acid in the stomach. So the nanoparticle reach the small bowel intact, and there they will be absorbed by the unique absorption mechanism that can be in three ways. He can go between the cells in the intestine, through the cells in the intestine, but mostly through a special cells called M cells that taken up the particle and release it to the lymphatic circulation. With the advantage of that is that the absorption area is not restricted to the duodenum and the first part of the jejunum. That is all through bowel. So that allowed the patient to absorb more and more and more iron when you compare with the traditional iron salts. And the other point is that the iron is never free. It's always inside the nanoparticle. So that avoid the contact of the iron with the intestinal cell and the side effect that caused by a traditional iron salt. That means the rate of gastrointestinal side effect caused by sucrosomial iron is 10 to 20 times less than with the traditional iron salt.
That's incredible. Mm-hmm.
And together that will have a very high absorption and a high bioavailability. So that improves the result. One is in the lymphatic circulation, he will go into the blood circulation and reach the target organ. But mostly it will be taken out by macrophages at the bone marrow and the liver and at the spleen. So that's why we see the effect relatively more rapidly than with oral iron, and in a similar way that what we can get with IV iron.
Wow.
Because we have all that together, and we can be convinced that the patient is taking the medication. What I expect at the end of the 3-month course that Melisa is having is that she will normalize her hemoglobin level, and she will normalize his ferritin levels. And that means she will be able to refill somehow her iron store. And that is what we have seen before. We have a study. There were 40 women with iron deficiency anemia caused by bariatric surgery. Initially they were receiving 300 milligrams of iron sucrose every 3 months, and in a moment we split these women in two groups. One group received the standard dose of iron sucrose, and the other one were receiving 30 milligrams of sucrosomial iron every day. 3 months later, the result was exactly the same in both groups. So that means that sucrosomial iron could be a good alternative to IV iron for treating iron deficiency anemia in this kind of patient. So what I expect a good result and at the correction of both anemia and iron deficiency in Melisa's case.
What a game changer for a group of patients that are going to have an absorption their entire life. Just the control that puts back into the patient's hands by being able to access the sucrosomial iron and having the formulary so that it survives the gastric stomach and can be absorbed all throughout the digestive system. It's going to be just fantastic.
Yeah, it is.
Yeah.
What about, are there any contradictions to taking Cedarel? For example, is the medication safe in pregnancy?
Well, in pregnancy, we have 2 randomized controlled trials, and we have a small trial with 80 women as a prophylaxis of iron deficiency and iron deficiency anemia in pregnancy.
Mm-hmm.
So we have 4 groups, one control group with no medication, one group having iron sulfate, 30 milligrams per day, and two groups having a sucrosomial iron either 14 or 28 milligram per day. And when we analyze the result at the end of the pregnancy, most of the women on sucrosomial iron avoid to have a iron deficiency anemia, have a higher ferritin level, and the recovery of postpartum anemia was much faster and more complete in those having sucrosomial iron. And regarding the fetus, there were not any side effect for the fetus. At birth, the newborn have an APGAR score similar to the other one at 5 minutes. And interestingly, the children from women having 28 milligram per day of sucrosomial iron have higher birth weight, around half a kilo, compared to the control. So I only can see advantages for that. And the other thing is that we have to take into account that iron deficiency during pregnancy will affect not only the mother but also the fetus, because a normal pregnancy need about 1 gram of extra iron to be complete, and the iron deficiency in the fetus can affect not only the growth and development of the fetus during the pregnancy, but even after the birth and in the early childhood. So we have to be very careful, and that's why in the Manhattan consensus statement we published a few years ago, we recommend to treat all women with iron prophylaxis since the beginning of the pregnancy and continuous prophylaxis at least 2 months after pregnancy. Most pregnant women stop taking iron sulfate because of gastrointestinal side effect, and that not happen with sucrosomial iron.
Fantastic.
Right. So that's the thing. If they can handle taking it, then they will take it and then it will work. Yeah. Yeah. That's awesome.
You also had some research on ulcerative colitis patients as well, correct?
Yeah, there is IBD is not only ulcerative colitis, but also Crohn's disease have been a target for this compound. There have been published a paper comparing ferric carboxymaltose intravenous with sucrosomial iron, and the result was actually the same. So all we know that for people with IBD, any of them, oral iron is poorly tolerated, and can reactivate the disease. So in most cases, again, we have to treat the patient to IV iron. But now with this compound, we can treat the patient with oral iron in a comfortable way at home. It's very exciting that the rate of gastrointestinal side effect in people with IBD is below 10%. On the other hand, because the mechanism of absorption of sucrosomial iron is independent of hepcidin, but hepcidin is a molecule that controls the iron absorption, blocking it. Anytime you have an infection or an inflammation, hepcidin is high and you cannot absorb all iron. But because over 90% of the absorption of sucrosomial iron is independent of hepcidin, then you can use it even in patients with inflammation. So that makes the advantage. You can give it to people with rheumatoid disease, with chronic heart failure, with IBD. In the postoperative period where we know for years that oral iron does not work, really we are now with I think it's a revolution in iron therapy.
Absolutely revolutionary. I like that word. Let's talk about the cost. Is it cost prohibitive? We know that to obtain Cedarol here in the United States, it's about $89, where we probably could get on the shelf lesser iron formularies for $8. Do you think that that's cost prohibitive for people?
No. No, we have to differentiate very clearly what is cost and what is value. So if something costs $8 but does not work,
Right.
it's very expensive.
Yes, it is. Right.
So if something costs a bit more, $89, but works,
Right.
then it's not expensive.
Right.
And if the alternative standard oral iron pills, he or she is intolerant to this or refractory to this medication, the other alternative is IV iron, which is very much expensive. So
very much.
Right.
then it's affordable.
Yes.
Even in Spain or in Europe, where the cost is much lower than in the US for IV iron, all the economical analysis we have done are in favor of sucrosomial iron. Probably it's the same problem you have in the US that we have in Europe. It is not a medicament; it's a supplement. It's a nutrition supplement.
Yep.
So I don't know how the insurance company can reimburse or not this amount. So this is something that I hope can be solved out in the next future. But indeed, I recommend my patients to use sucrosomial iron, correct iron deficiency anemia, before trying to use IVR. Well, unless I need a very, very rapid reposition of iron deposit, then I have to go to IV iron, obviously. No, but for a chronic treatment, I think it's a perfect molecule. I said again, it's with almost no side effect. It's very comfortable. You can have at home. You don't that don't disturb your social life or your working life or your family life because you don't have to go to anywhere. So I think the value was the cost.
Definitely.
Yeah, definitely. Dr. Munoz, is there a minimum starting age for the medication?
Sorry?
Like, can a pediatric patient take this medication?
The pediatric patient can take the medication.
Okay.
I don't know in US, but in Spain we have a formulation for children.
Okay.
And in fact, there is a very, very recent paper published in IBD children with IBD. Again, comparing, they were treated with sucrosomial iron or ferric malto plus sucrosomial iron, and they were very, very well tolerated, and the final result was actually the same in both groups. So sucrosomial iron is a good solution when you have certain amount of time, and if you are in a hurry, you can give one dose of IV iron and then complete the treatment with sucrosomial iron. So because this is another advantage of the sucrosomial iron. If you give IV iron, you will not absorb traditional iron salts, but this will not affect to sucrosomial iron.
Okay.
Because the absorption mechanism is different.
All right.
Sometimes we do this combination, just give, let's say, 500 milligrams of ferric maltose, and then continue the rest of the treatment with sucrosomial iron.
Okay.
And again, the total cost of the treatment is much lower than if you use only IV iron.
Sure. And it works.
Yeah, the options are incredible, really, that you can use it and utilize it. I'm really excited for the anemia population to have Cedarol available to them. Also, that they don't necessarily have to get their PCP or their provider to agree that this is something that's affecting them, that they don't have to worry about the costs. I like that they can just on a website order the product, and it kind of gives them some power over their own health, I guess. Of course, we do want them to be using it in conjunction with their primary care provider. We want them to understand the value of having that communication and that partnership with their provider. My question is, with some iron formularies, such as IV iron, you have to worry about iron overload. Could someone, since they do have the ability to take cedarol, and let's say they're doing it just by themselves, could they overdose on their iron?
This is really, really, really difficult. I mean, the standard dose is 30 milligrams. First of all, that you only have to take sucrosomial iron if you have iron deficiency, right?
Right.
Or if you are in a situation that you can develop iron deficiency and you want to avoid it.
Mm-hmm.
If you don't have iron deficiency, don't take anything.
Right.
Well,
Right.
if you have iron deficiency, the dose of iron that we are giving to the patient is normally 30 to 60 milligrams. So it's no risk of iron overload. Remember that traditionally we were prescribing the patient oral iron, let's say iron sulfate, 80 to 100 milligram elemental iron, 2-3 times in a day.
Yes.
Yeah, compare that with just 30 milligram elemental iron that you are giving with sucrosomial iron. So one population that is very much at risk of being exposed to iron overload is chronic kidney disease patients. They have to have oral iron for iron supplementation for their life. And the data we have in this population, up to 1 year of treatment, is that ferritin never goes above 100. So the nephrologists sometimes complain, well, you are not replating properly the iron. So I say, okay, that's your point of view. My point of view is that I'm correcting the anemia, I'm correcting the iron deficiency, and I'm not taking the risk of iron overload. So for me, it's okay. So I think for a standard treatment that for an occasional iron deficiency, that could be 2, 3, 4 months, and 6 months maximum, there is no risk at all of iron overload. And for chronic treatment, of course, you have to have a follow-up. If you are, in the case of Melisa, she must have a lab measurement at least once a year. Mm-hmm. We can know if we can increase or reduce the dose. The probability to have an iron overload, if you properly manage the compound, is very, very, very small.
This is so exciting. Thank you so much for sharing all this information and helping us to realize that this is useful and valuable in many different clinical situations and for all genders. And this has been just so enlightening for me. And I'm really excited about this medication. And I'm excited to see how Melissa's lab results come back in a couple of weeks. This has been a great topic to discuss right around World Anemia Awareness Day. That's coming up soon, right? The 13th.
Yes.
They picked that number because we want everyone to correct their anemia and have a hemoglobin close to 13, no matter what their gender is. We want to shoot for people to have a hemoglobin near 13. Yeah, this is so exciting. And don't we have something coming up special for World Anemia Awareness Day, Sarah?
Yeah, well, I think because it is World Anemia Awareness, I'd like to share the top 13 signs and symptoms of anemia so that you can look at yourself and say, am I experiencing some of this? Should I have my CBC and my iron checked? So the top 13, according to Chat GPT, is fatigue, weakness, pale or sallow skin, dizziness or lightheadedness, cold hands and feet, headaches, irregular heartbeats, chest pain, cognitive problems, brittle nails, restless leg syndromes, and unusual non-food cravings such as pica, which is a desire to eat dirt or even ice. If you are experiencing any of those symptoms, they may seem very small in nature, but they are affecting your quality of life, and it's worth having your blood count and your iron checked. We are going to share our link with our audience on how they can obtain Cedarol. So we will share the link. And if you put the coupon code, Let's Talk PBM, you will have a 10% discount. And it does ship with no charge.
Thank you, Sarah. And we'll link some of the articles from Dr. Munoz as well, correct?
Absolutely. Absolutely. Yeah. Dr. Munoz, what takeaway would you like our audience to leave with today?
Well, I think that there is a few take-home messages that I want to remark. One is that iron deficiency is very frequent among a variety of clinical conditions and even in apparently healthy people.
Mm-hmm.
Secondly, that when we want to treat it, oral iron salt sometimes work beautifully, but most of the time have a gastrointestinal side effect that diminish the compliance with the treatment. And you remember, the main reason for oral iron not to work is the patient don't take it.
Right.
Mm-hmm.
Third, that in some cases it will be useful to have IV iron, but it's expensive. You need to go to a clinic. It's time consuming, and it's not free of side effects. And some of them, even when they are rare, could be life-threatening. So you have to take that into account when you decide to have IVN. And that is that sucrosomial iron. Again, perhaps I'm repeating my words, but I think is a compound that can to fill the gap between oral iron and IV iron and could have, I think most patients with ID should give an opportunity to this compound. Their bodies will appreciate it very much.
Melissa, what would you like our audience to know?
Well, first I want to thank Marianne and Sarah for having me on today and letting me tell my story. It's important to me. It's important to learn more about it. So I appreciate that, the platform I was given today. I guess to other bypass patients or anemia patients, just don't give up, particularly the bypass patients. Don't give up. I'm 16 years post-op. I'm still reaping the benefits. I have a life that I would not have had before. And yes, there have been some downsides, the anemia, the exhaustion, the things like that. But the benefits far outweigh. I have 3 healthy children that I can keep up with and that are proud of their mother. And that means more to me than anything. So just don't give up. Your day will come. You'll find your solution.
You're such an inspiration to all of them. Thank you for being here today.
Anytime. Thank you, ladies.
We hope you enjoyed this conversation and found some takeaway or new thought that improves your health. We would love to hear from you. Feel free to reach out to us on our website if you'd like to see what we're up to. Our website is letstalkpbm.com. If you enjoy our conversations, please like and subscribe wherever you listen to podcasts and on our YouTube channel.
Special thanks to our guest and our producer, Delaney Coronado, and the entire production team for all of their expertise in content creation, technical abilities, and dedication to our message. We appreciate the experts who drive this medical movement forward, and our affiliate partnerships who support the work that we are doing. Until next time, stay connected to your blood health.